Okay.
Your heart is a pump. It's a muscular organ about the size of your fist and is located slightly left of center in your chest. Your heart is divided into the right and left side. The division protects oxygen-rich blood from mixing with oxygen-poor blood. Together, your heart and blood vessels comprise your cardiovascular system, which circulates blood and oxygen around your body. In fact, your heart pumps about 5 quarts of blood every minute, and it beats about 100,000 times in one day. That's about 35 million times in a year. Oxygen-poor blood, blue blood, returns to the heart after circulating through your body. The right side of the heart, composed of the right atrium and ventricle, collects and pumps the blood to the lungs through the pulmonary arteries. The lungs refresh the blood with a new supply of oxygen, making it turn red. Oxygen-rich blood, red blood, then enters the left side of the heart, composed of the left atrium and ventricle, and is pumped through the aorta to the body to supply tissues with oxygen. 4 valves within your heart keep your blood moving the right way. The tricuspid, mitral, pulmonary, and aortic valves work like gates on a fence. They open only one way and only when pushed on. Each valve opens and closes once per heartbeat, or about once every second. A beating heart contracts and relaxes. Contraction is called systole, and relaxing is called diastole. During systole, your ventricles contract, forcing blood into the vessels going to your lungs and body, much like ketchup being forced out of a squeeze bottle. The right ventricle contracts a little bit before the left ventricle does. Your ventricles then relax during diastole and are filled with blood coming from the upper chambers, the left and right atria. Then the cycle starts over again. Your heart is nourished by blood too. Blood vessels called coronary arteries extend over the surface of your heart and branch into smaller capillaries. Here you can see just the network of blood vessels that feed your heart with oxygen-rich blood. Your heart also has electrical wiring, which keeps it beating. Electrical impulses begin high in the right atrium and travel through specialized pathways to the ventricles, delivering the signal to pump. The conduction system keeps your heart beating in a coordinated and normal rhythm, which in turn keeps blood circulating. The continuous exchange of oxygen-rich blood with oxygen-poor blood is what keeps you alive.
Okay. So that was the normal anatomy and physiology of your cardiovascular system. If you open page number 227, from there you will have all the diagrams for the cardiovascular system, 227, where they have mentioned the course of aorta. So in the last class, when we just discussed about the nervous system, I explained this course of aorta to you. So aorta, it originates into your heart, then it is going to arch down into your chest cavity. Once it descends down into the chest cavity, that part of the aorta which is lying into the chest cavity is called as the thoracic aorta, descending thoracic aorta. When this aorta is going to pass below the level of the diaphragm, it is called as abdominal aorta. Abdominal aorta further goes down. When it goes below the level of the kidneys, it is called as infrarenal aorta. This infrarenal aorta further goes down and it divides into 2 major branches called as common iliac arteries to supply blood to your lower extremity. So that is what is the course of aorta. Now, this course of aorta I explained again because whenever it comes down to coding into cardiovascular system, your codes are basically divided into 3 parts. The first part deals with the heart and all the procedures related to pericardium. So, heart as an organ and the pericardium, that is the protective membrane of the heart. So any procedures performed on these body parts, the codes will be listed into the first part of the chapter. Then comes the second part of the chapter, which deals with the internal structures of the heart, that is your heart valves and the great vessels. Great vessels are the vessels which are directly connected to the heart. like your superior vena cava, inferior vena cava, aorta, pulmonary artery, pulmonary veins. These vessels are directly connected to your heart. So any procedures related to these vessels will be listed into the second part. And then comes the third part of the chapter, which deals with the other vessels in the body. So you have got different arteries and veins into your body. So any procedures performed onto the peripheral vessels in the body, the codes will be listed into the third part. So there are three parts to this particular chapter. First part deals with the heart and pericardium. Second part is the internal structures of the heart and great vessels. And the third part is all related to the peripheral vessels in the body. So that is why I explained the course of aorta. And when we are going to deal with the peripheral vessels, they have arranged the codes for these vessels in the descending order, from top to bottom in the descending order. How the vessels will course into the body, based on that, the codes will be arranged for the peripheral vessels, and that's why you need to know the course of aorta, because the first part of aorta is thoracic aorta, then abdominal aorta, then infrarenal aorta, and then lastly common iliac artery. So your codes will be arranged in the same order from top to bottom in the descending order. And that's why you have to know the codes. Coming to the next diagram, that is the heart and the internal structures, we have already discussed and I played the video also. So all the compartments of the heart, the valves located inside the heart, and then the great vessels, everything, the flow of the blood, how the blood will flow through the entire compartments of the heart, and everything that is shown in this diagram. The next diagram is for all the vessels in the body, specifically arteries. You have got two types of vessels, arteries and veins. So everywhere you have got these vessels in your body to supply blood and to carry this blood back to the heart. Arteries will always carry oxygenated blood away from heart to different parts of the body, and veins will carry blood from different parts of the body back to the heart, and they carry deoxygenated blood. So this is the diagram representing arteries in the body. You have to know which artery is located where. I am not expecting you to memorize the names of all these arteries, because there are all various different arteries into different parts of the body, and depending on where they are located, their names are also different. So these vessels, their names, I'm not expecting you to memorize, but this diagram you have to know it's there, because certain times to certain procedure there are exceptions. Like when we are going to code for the bypass grafting surgery. So we do not code the procurement of the grafts depending on which graft is being procured, whether you take up the vessel from the lower extremity, from a upper extremity, or from the abdomen. So which vessel you are going to procure, certain exceptions will be there. For that, you have to know the vessel is located into upper extremity or lower extremity, abdomen, or some which part of the body. That you have to know. Doctor will simply name the vessel. That is procuring, say, femoropopliteal artery, is procuring, say, radial artery. So you need to know which vessel is located where to code for it. And that's why these diagrams, you have to know where these are located. Just a minute. Yes. Okay. So I was explaining this arteries into your body. The next diagram, if you see, it is for the veins into the body. So there are different veins. So again, the names of the veins, I don't expect you to remember. But this veins, which vein is located where, you have to know that. And that's why this diagram is there. You can refer to these diagrams. The next diagram, if you see, is for the upper extremity. All the vessels which belong, be it artery or vein, which belong to upper extremity, they have given into this diagram specifically. Apart from the other diagrams, this diagram is specifically given for the upper extremity. Why? Because this is the closest route to reach out to your heart. If you don't want to do an open heart surgery, then you can reach out to your heart by pushing the catheters from the upper extremity and thread it down to your heart. And that's why the vessels of the upper extremity, these are specifically given into this diagram. You can just like remember this, hardly few names are there. So which all arteries and which all veins are located onto the upper extremity. You can memorize these names. Not others, but this at least you can memorize. So that was all about the vessels in the body. The next diagram is for the lymphatic system. So as we are learning about the circulatory system, this chapter is all about circulatory system, but they have clubbed the lymphatic system along with the circulatory system. Okay. So at the end of circulatory system, you will see the codes related to lymphatic system. Once we finish all this the procedures related to circulatory system, at the end you will see the codes related to lymphatic system. So as the blood is circulating all over the body, same way the lymph is also circulating everywhere into the body. Lymph is nothing but this particular system produces antibodies, that is WBCs are being produced. So if you know, WBCs are a part of your blood. So they are also circulating all over the body. Same way, the lymph is also circulating all over the body. And it is composed of your lymph channels, lymph nodes, lymph glands are there. So the codes related to that you will find into the end of this chapter. Now coming to the actual codes into the circulatory system. So as I said, your codes are divided into three parts. The first part we will start with. So here, heart and pericardium. Any procedure you are going to perform on heart or pericardium, the codes are listed in here. This particular, in the beginning, you have codes for pericardium. Pericardium is the protective membrane of your heart. Pericardium, these are two membranes basically. One is close to the organ, and over that, another membrane which is distant to the organ. So between these two membranes, you are going to have a fluid. These membranes, the one which is closer to the organ is called as visceral layer of the pericardium, and the one above it is called as the parietal layer of the pericardium. Whenever any procedure is performed for this pericardial membrane, maybe the membrane is damaged or there is a tumor or you need a biopsy sample or you need to collect some fluid, that is the fluid around the heart to protect the heart. So you need to collect that fluid as a biopsy sample, or maybe for certain investigations related to infections or some other reason. Any procedure for that matter you do for this pericardial fluid or for the pericardial membrane, all procedures are listed here. Be it excision procedure, incision procedure, biopsy procedure, whatever kind of procedure it is, the codes are listed here under this section, that is pericardium. You don't have to go anywhere else. The next procedure you will see is the cardiac tumor. So if the patient has a cardiac tumor over the surface of the heart, if there is a tumor, then to treat the tumor, either you get it removed, that is excision you do. Sometimes it's not possible to remove the entire tumor, so you resect it. Some part of the tumor which is possible to get removed, that part of the tumor you will remove. So that is resection procedure. So either you do resection or you do excision. Whatever you do, based on that, you assign the codes. No specific guidelines for coding this cardiac tumor. The next procedure, if you see, is myocardial revascularization. So this particular procedure has only got one code and one add-on code is there. So you just have to read the description. Whatever description matches with your patient's record, based on that, a code and the add-on code if needed, you have to use it. Otherwise, you simply code by 33140. There are no guidelines for coding this procedure either. Coming to the next procedure, that is pacemakers or defibrillators. To understand pacemakers or defibrillators, you have to know what this is all about. Pacemaker why you have a pacemaker in your body? Whenever you know there is a electrical conducting system into your body, that SA node generates a electrical impulse, and that electrical impulse is going to spread all over the cardiac muscles so that the muscles will contract. This SA node generates an electrical impulse at a regular interval, but if this SA node fails to generate that electrical impulse, then your patient lands up into a cardiac arrest. To avoid this, so when SA node is not functioning properly, it is called as a natural pacemaker of your body. When it doesn't function properly, then you get the device, that is a pacemaker device, inserted into the patient's body. This pacemaker device comes up with two parts. Like in the last class, we discussed about the neurostimulators. They do have a battery and an electrode. Similar way, pacemaker also has a battery and an electrode. This circular structure, if you seen here, it is called as a battery, or it is also called as a pulse generator. And then this pulse generator is connected to this wire-like structure which is placed inside the cardiac chambers, that is called as a lead, or you call it as an electrode. So these are the two parts to any pacemaker. Depending on how many leads are there to the pacemaker, pacemakers are classified into three types. So here what you see is two leads are there. One lead is placed into right atrium, the other lead is placed into the right ventricle. So it's called as a dual chamber pacemaker, or you call it as a dual lead pacemaker because two leads are there. But what if there is only one lead, one electrode? You don't need two electrodes, you need only one electrode. Then you call it as a single lead pacemaker. So single lead, dual lead, or multi-lead pacemaker will be there. So multi-lead pacemaker, usually more than two leads will be there. Three or more, but usually three will be there. So then you call it as a multi-lead pacemaker. So depending on how many leads you use for a pacemaker, the pacemakers are classified into single lead, dual lead, or multi-lead pacemakers. Now, as we discussed, these are the types of pacemakers depending on the number of leads. But pacemakers are also classified depending on how these leads are placed into the body. So if your doctor is going to push the leads through the vein, like you see in this diagram, this blue structure, what they have shown is a subclavian vein. Usually they push the electrodes through this vein and push it into the heart. So when they do so, it's called as a transvenous pacemaker. So through the vein you are pushing it, that's why transvenous pacemaker. But sometimes you are not going to push these leads through the when instead you do a open surgery, cut open the patient's chest, and directly over the surface of the heart you place the leads. Then you call it as a epicardial pacemaker. Epi means over, cardium is your heart. So over the surface of the heart, when you place the leads, it is called as a epicardial pacemaker. And then there is another type called as a leadless pacemaker. Leadless pacemaker, here in the diagram you see there is a battery and an electrode, two separate parts are there. But leadless pacemaker comes as a single capsule-like structure. One pellet or capsule-like structure will be there. Inside that, everything is inbuilt. The leads and the batteries and everything is inbuilt into the capsule. You just push that capsule into the right ventricle. It will get fixed there, opposing the walls of the right ventricle. So that is what is you call it as a leadless pacemaker. So three types of pacemaker depending on how the leads are placed. One is a transvenous pacemaker. The other is a epicardial pacemaker, and the third is a leadless pacemaker. Every time whenever you are going to code for pacemakers, you have to understand what type of pacemaker the doctor is dealing with, because codes will change depending on the type of pacemaker. Another thing is what they do with the pacemaker, whether they are inserting the pacemaker, removing it, or replacing some part of the pacemaker, repairing some part of the pacemaker, that you have to check. What procedure they do with the pacemaker, what is the type of the pacemaker. These two things you have to match, and then you can choose your codes. This is all about pacemaker. Similar to pacemaker, you have another device called as defibrillator. Defibrillator also has got same structure. It will also have a battery and it will also have a lead. The only difference between a pacemaker and a defibrillator is pacemakers are used for short duration. Like for few days to months, you can have a pacemaker in the body. But if it's a defibrillator, you can have it for years together in your body. So when your patient's heart condition is very weak and you know that it's not going to improve, you prefer to insert a defibrillator. You can have that defibrillator for years together, like 10 years, 12 years or more. You can have that in the body. Defibrillator also is classified into three types depending on the number of leads attached to the defibrillator. That is single lead, dual lead, or multi-lead defibrillator. Again, based on how the leads are placed into the body for the defibrillator, defibrillators also are classified into three types. One is a transvenous defibrillator like transvenous pacemaker. The other two types are different than pacemaker. So the other two types of the defibrillator are subcutaneous defibrillator and substernal defibrillator. Cutis is your skin. So when you are going to place the leads below the skin, you call it as subcutaneous pacemaker. So you don't have to do a open heart surgery. You simply cut open the skin on the chest near to the heart, and below the skin you place these electrodes. So that is what is you call it as a subcutaneous pacemaker. The third one is substernal pacemaker. Sternum, if you understand, it's a bone in the middle of your chest where all the ribs are attached. That bone, below the bone, if you place these leads, then it is called as a substernal pacemaker. So, three types of, I'm saying pacemaker, it's a defibrillator, okay? So, substernal defibrillator. So, three types of defibrillator: transvenous defibrillator, subcutaneous defibrillator, and substernal defibrillator. These are the types of defibrillator based on their position of the leads into the body. Again, for the defibrillator, when you are going to code, first you have to know what they are doing with the defibrillator. They are inserting, removing, replacing, or repairing some part of the defibrillator. Check that. And secondly, you match the type of the defibrillator and then you can choose your codes. So always when it comes down to coding for pacemakers and defibrillator, you have to know which device it is, what is the type of the device, and what they are going to do with the device. Based on these three things, you are going to choose your codes. The codes are not that simple, and many times you will have a question on this part. So to make you understand more about this pacemakers and defibrillators, I'll just play a video so that you'll understand all different types of pacemakers and defibrillators, and then we will go and check the codes for this pacemakers and defibrillators. Okay.
Implantable pacemakers and defibrillators are devices that apply electric shocks to maintain the rhythm of the heart and, if necessary, restart it. As the technology improves and the list of treatable conditions grows, the number of devices being implanted is increasing steadily and now exceeds 500,000 a year. The heart is made up of 4 chambers, 2 atria and 2 ventricles. On each side, the atrium is connected to the ventricle by a one-way valve. Blood is pumped as these chambers contract and relax in turn. The beating of a healthy heart is regulated by electrical impulses. The sequence begins as the atria fill with deoxygenated blood from the body on the right and oxygenated blood from the lungs on the left. An electrical signal from the sinoatrial node then causes the atria to contract, forcing blood into the ventricles. The electrical signal is then picked up by the atrioventricular node and directed into the Purkinje fibers in the ventricle walls, causing the ventricles to contract. And the blood is then pumped through the pulmonary valve on the right to the lungs and the aortic valve on the left to the rest of the body. These valves close and the cycle then restarts. When the sinoatrial node fails to function correctly, an artificial pacemaker can be fitted to help regulate the heartbeat with small, evenly timed electric shocks. This involves implanting electrodes into one or more of the heart's chambers by inserting leads into a vein near the collarbone and implanting a device called the generator just under the skin. For more severe heart conditions, an implantable defibrillator, or ICD, can be used, which is also capable of sensing a stopped heart and delivering an electric shock powerful enough to restart it. For some conditions, an even more sophisticated device, called a CRT ICD, can be implanted. This uses a third lead inserted into the left ventricle to resynchronize the ventricles when necessary. However, all these leads can cause problems of their own. Patients with ICDs have a 20% chance of a lead failure within 10 years, and replacing leads can require open heart surgery in about 2% of cases. This has resulted in several efforts to develop new pacemakers that do not depend on leads inside the heart. One design, the subcutaneous ICD, places the lead just outside the heart under the patient's skin. And wireless designs are now being developed that may eventually do away with the need for leads altogether.
I hope that is clear. So how the leads are placed and how they function. Now coming to the codes, so pacemakers and defibrillators. Whatever guidelines or whatever explanation I just gave, everything is written here below this pacemakers and defibrillator. If you see the very first line, they have given the definition of a pacemaker. A pacemaker system with leads include a pulse generator containing electronics, a battery, and one or more leads. That is your pacemaker. That same paragraph, last three lines of the paragraphs, if you see, they have given the types of pacemaker depending on the position of the lead. So leads may be inserted through a vein, then you call it as transvenous pacemaker, or they may be placed on the surface of the heart, then you call it as a epicardial pacemaker. Then the next paragraph, if you see, they have given the explanation about the single and dual lead pacemakers. So single chamber pacemaker or single lead pacemaker system with lead includes a pulse generator and one electrode inserted in either atrium or ventricle. So when it's one single lead, you can place it either into atrium or into ventricle. A dual lead or dual chamber pacemaker system with two leads includes a pulse generator and one lead inserted into the right atrium and the other lead inserted into the right ventricle. So when it's dual lead, you place it in both the places. So that is about single lead, dual lead explanation is given. Next paragraph, first line, if you see, they have given about the leadless pacemaker. So leadless pacemaker system includes the pulse generator with built-in battery and electrode. So everything is built in inside. That is what is a leadless pacemaker. If you come this side, the third paragraph on this side, you will see they have given the this definition for defibrillators. Okay, all different types of defibrillators. So like a pacemaker system, an implantable defibrillator system includes a pulse generator and electrodes. Three general categories of the implantable defibrillator exist. That is transvenous implantable pacing cardioverter defibrillator, subcutaneous implantable defibrillator, and the substernal implantable defibrillator. That is, the subcutaneous defibrillator is also in short called as SICD. And when it's transvenous defibrillator, it is in short called as ICD. So better you remember the short forms also. ICD and SICD, usually with the when they ask questions, they will use short forms. You have to know what it stands for. That was all about the definitions of your defibrillator, pacemakers, and the types of pacemaker. If you turn your page number 239. Page number 239, if you go to, you will see they have given the definitions of single lead, dual lead, and multi-lead pacemakers there. Okay. So single, dual, and multi-lead, we have already explained. So going forward to the codes now. The code starts on this page 239 from the code 33202 till and 203. Now, whatever codes I'm saying, these are together. Mark them as together. And whatever description I have highlighted, better if you also highlight it. It will be easy for you to later on find the codes. Okay. So here, whenever you are going to code, I asked you to check for three things. First, check for the type of the device. Then check the what they are doing with the device, inserting, removing, and exactly sometimes what they do is they deal with the entire device. Entire device as in the batteries as well as electrodes, they are going to insert together. Sometimes already the patient has a pacemaker in the body, so I'm removing the old batteries and inserting the new ones. So that is what is, you have to understand only with the battery, only with the electrode, or with the entire device the doctor is performing the procedure. Based on that, you have to assign the codes. So here the first two codes are together, 33202 and 2203. These are for the system, that is epicardial pacemaker. The type of the device is epicardial pacemaker. And these codes are for insertion of electrode for epicardial pacemaker. Only electrodes, not the battery. If you insert only electrodes and you're not connecting it to the battery, it will not function. So these are the codes only for insertion of electrode. Usually along with this code, you have to use another code for insertion of the battery. Because if you do not insert the battery, the device is not going to work. So these codes are only for insertion of the electrode. And this codes one code. So like I told you, epicardial pacemaker, when you just have to place the electrodes over the surface of the heart, you cut open the patient, place it over. So that is a thoracotomy procedure. You cut open the chest, it's called as a thoracotomy if it's open procedure. But the other way to do it is endoscopically. So you always have that option of a closed procedure. So if you do it endoscopically, the code is 33203. If you do a open procedure, the code is 33202 by thoracotomy. So that is these two codes for the insertion of electrodes for epicardial pacemaker. Below that, can you see the note? After the code 203, there is a note. If you see that note, they mention when epicardial lead placement is performed with insertion of the generator. These codes are for the lead placement, that is electrode. Along with that, if you are placing a generator, that is a battery, then you have to use these codes in conjunction with multiple codes they have given. So you have to use these codes for the placement of battery, depending on the type of system, single lead, dual lead, multi-lead, and so on. You have to use separate code for insertion of battery, and that is what is mentioned in the note. Better you always read the notes below your codes. So if any additional code is required, then you will get to know which code has to be assigned furthermore. That was for epicardial pacemaker. The next three codes, if you see, 33206, 7, and 8. These three codes are together. These codes are for the insertion of transvenous pacemaker now. Earlier code was for epicardial pacemaker. Now these three codes are for the transvenous pacemaker if the entire device, when I say entire device, I'm talking about the battery as well as lead. So if the entire device is being placed, then you use one of these codes, depending on whether it was a single lead device or a dual lead device you are going to insert. Based on that, you are going to use the code. So of that, 33206 and 207. These are the codes when you are going to insert a single lead transvenous pacemaker. So when it's a single lead, either you place the lead into either atrium or into ventricle. So where you have placed the lead, you have to check. And sorry, based on that, you are going to use the code either 206 or 7. The next code 33208, it is for insertion of the transvenous pacemaker, but when it's a dual lead pacemaker, where in dual lead you place two leads. And these leads, one is into the atrium, the other is into the ventricle. So into atrium and ventricle, when in two places the leads are placed, you use the code 33208. These are the codes for the insertion of entire device. If you read the description of the code 33206, 33206 says insertion of new or replacement of permanent pacemaker with transvenous electrodes, atrial. So here in the description, they have mentioned insertion of new or replacement of the permanent pacemaker. Though they have used the word replacement, that doesn't mean the actual replacement. Okay, replacement is patient already has some device in the body, you take out the old one and you insert a new one. That is called as a replacement. This code directly you cannot use for replacement. Why? Because replacement needs removal of the old device. This code is only for the insertion of the new device. Okay. This code is only for the insertion of the new device. Before that, you have to get the old device removed, and for the removal of the old device, separate codes will be available. So do not use this code directly for replacement. One single code for replacement is never assigned. You have to code for removal separately, and you code for the insertion of the new device separately. Okay. So even when the word replacement is written, do not use that direct code for replacement. That was for the transvenous pacemaker. If you go to the next two codes, 33210 and 211, these codes are for the replacement of electrodes alone. Okay. So, not replacement, insertion of the electrodes alone for the pacemaker. Whenever you are going to insert only electrodes, that to temporary pacemaker. Temporary meaning usually when patients are undergoing cardiac surgery. For many times when the heart is functional, it's beating, you cannot perform a surgery on the heart. So doctors will stop that heart, and the function of the heart will be taken over by a device called as a what is it? Cardiopulmonary bypass. It's a device to bypass the function of the heart and lungs. So this device will take over the function of your heart. So whenever they are going to stop the heart, then again after the surgery is done, you need to restart the heart. So when you need to restart the heart, you will have this temporary pacemaker in the body. Just for time being, you need it. And then later on, you just don't need it because your heart will start beating on its own. So that is why for the insertion of the temporary electrodes, only temporary electrodes, if you need to code it, then you code with 33210 or 211, depending on whether it was a single lead or a dual lead device. Okay. Next three codes. If you see 33212, 213 or 221. These three codes are for insertion of the battery. Earlier two codes we saw for insertion of electrode alone, that too for temporary electrode. Now these three codes are for insertion of batteries only. If you need to only insert the batteries of the pacemaker, then you use one of these codes depending on whether it's a single lead, dual lead or multi-lead battery you're inserting. Based on that, you choose one code. The next code, that is 33214, it is for upgradation of the system. What is upgradation? Say my patient had single lead device in his body. Now patient's heart condition is deteriorating. So that single lead is not sufficient for the patient. I need a dual lead for the patient. So I don't have to rework everything. Already one lead is there in the body, battery is there in the body. I insert one more lead and attach to the batteries. So my job is just a partial work I have to do. So for upgradation of the system from single lead to dual lead, you can use this code 33214. You don't have to code for the insertion of the entire device or replacement or nothing. Just one more lead you have to add, and that is what is you code with 33214. The next two codes, that is sorry, not two codes, this code 33215. So from this code onward, if you see from 33215 onwards till 223, from 215 till 223, whatever codes are there, these can be used for pacemaker as well as for defibrillator. So far, before 215, whatever codes we discussed, those were only for pacemakers, be it epicardial pacemaker, transvenous pacemaker, but only for pacemakers, you can use those codes. From 215 onwards till 223, whatever these codes are, you are going to use them either for pacemaker or you can use them for defibrillator also. So this particular code 33215, it is for repositioning of the electrode. What is repositioning of the electrode? Say already I have a single lead device in the patient's body. Earlier I have kept the electrode into right atrium. But now I don't need it, the pacemaking into right atrium. Maybe I need it into the ventricle. So what I'll do is, whatever that electrode is, I'm just going to push it down little into the ventricle. So already electrode is there, battery is there. Only the position of the electrode I'm going to change from right atrium to right ventricle. That is what is you call it as repositioning. So if you reposition the electrode, the code is 33215. Be it for pacemaker or defibrillator, you can use that code. The next two codes, if you see, 33216 and 7. These are the codes, again can be used for pacemakers or defibrillator. These are for insertion of permanent electrode. Earlier we saw for the insertion of temporary electrodes, there were codes. Now these are the codes for insertion of permanent electrode when you need a pacemaker or defibrillator for a longer duration. Then you are going to code with this insertion of electrodes either 33216 or 217, depending on whether it's a single lead or a dual lead system. Next two codes 33218 and 220. So 218 and 220, these are the codes for repair of the electrode. Already electrode is there, battery is there, but somehow the electrode is damaged, and that same electrode, I'm not going to change it. I'm going to repair that old electrode itself. These devices are very expensive. You just cannot remove and throw them off. You just try to repair if there is some minor damage. So if I'm going to repair the electrode, the code is either 33218 or 220, depending on single lead or dual lead system. The next two codes 33222 and 33223. These are the two codes for relocation of the electrode. Already electrode is there. Sorry, relocation of the batteries. These are the codes for relocation of the battery, not electrode. So battery, if you have paid attention to the video, and there they have mentioned below the clavicle. So that is your collarbone. Below this collarbone, they will create a skin pocket. Into the skin pocket, they are going to place these batteries. Whenever the batteries are there, say I want to relocate these batteries, it will be a bump below the collarbone. Maybe patient is not comfortable with that, or maybe there is some damage to that location, or some infection is there, or some complication is there. So I need to remove the batteries from there and place it somewhere else in the body. So if I'm going to relocate the batteries only, then I code with 33222 if it's a pacemaker battery, and I code with 33223 if it's a defibrillator battery. So which device batteries are being relocated, check that, pacemaker or defibrillator, and assign one of these codes. These codes, they in the description they have mentioned not the word battery is not used, or a pulse generator, that word is not used. Okay, they have used the word skin pocket. Skin pocket is usually created for the batteries only, not for electrodes. So even if they ask you for relocation of battery or relocation of the pulse generator, you use these codes. They have mentioned it to be a relocation of skin pocket. Then later on this codes, two codes, you can leave it in between. Come down to the code that is 33233. The code 33233. Now, from this code onwards, you will see the codes are again for pacemakers alone. Okay, everything hereafter is now for pacemakers. So, 33233, it is for removal of the batteries of pacemaker. Whenever I'm going to remove only batteries and being removed, only for removal of the batteries, you code with 33233. The next three codes, that is 332. 227, 228, and 229. These three codes are for replacement of battery. So this code you can directly use for replacement. Earlier when we saw the description, it was insertion of new or replacement of the pacemaker. There I told you do not use that code directly for replacement. But now if you read the description of this code 33227, it says removal of permanent pacemaker pulse generator with replacement of the pacemaker pulse generator. So they are removing. Removal is also mentioned with the code description, and along with that replacement is also mentioned. So I can use this code when they remove the old battery and replace with the new batteries. I can directly use this code. So when it's replacement of battery for any device, you do have separate codes available, directly one single code. But if it's a replacement of electrode, For replacement of electrode, no direct code available. So if it's replacement of electrode being done, you code for removal of the old electrode separately and insertion of the new electrode separately. Even when it's replacement of entire device. So for a replacement of entire device also, you don't have a direct code. So you code for removal of each part of the device and then you code for the insertion of the new device. Okay, so separate codes you have to use when it's in replacement of device or replacement of electrode, separate codes for removal and insertion to be used. But when it's replacement of battery, you do have direct codes. One single code can be used. So that is 33227, 228 and 229. These are the codes for replacement of battery. Depending on whether it's single lead, dual lead or multi-lead device, you use one code. The next two codes, that is 33234, 235 and the other code, that is 33238. These codes are together 234, 235 and 238. These are the codes for removal of electrode. Whenever electrode is removed, so you know electrodes, usually when it's a transvenous pacemaker, I push the electrodes through the vein. So as here in the diagram, if you see, I'm pushing the electrodes through the vein. If I want to remove the electrodes, how I will remove it? The simplest way to remove it is wherever the outer end of the electrode is, I cut it open there and I just slowly pull the electrodes through the vein. That is called as a transvenous extraction of the electrode. Through the vein, I am pulling them off. But sometimes there are complications, your patient's condition is critical, or maybe the electrodes are stuck somewhere, or the vessel is damaged, something is the problem. In that scenario, I cannot pull them off through the vein. Then I have to do a open surgery, cut open the patient entirely, cut open the heart, and then get the electrodes removed. That is called as a removal of the electrodes by thoracotomy. Okay, you just have to cut open the chest and get them removed. So if I do a transvenous extraction, for transvenous extraction, these are the two codes 33234 and 235. Removal of electrodes, depending on whether it's single lead or multi-lead device. Based on that, you choose this code, either 234 or 235. And the code 33238. That code 238 is for the removal of the electrodes by thoracotomy. So you just are going to cut open the patient and remove it. Then you use this code, that is removal of electrodes by thoracotomy. Then in between the two codes are there, that is 33236 and 237. These two codes are also for removal of electrode, but the type of device is epicardial pacemaker. It's not transvenous pacemaker anymore. When it's a epicardial pacemaker and I want to remove the electrodes of the epicardial pacemaker, I use this code 33236 or 237, depending on single lead or dual lead. Now, when it's epicardial pacemaker, I have already placed the electrode over the surface of the heart. Okay. Now, to get it removed, I always have to do an open surgery. I cannot remove it by any other method, but I have to do an open surgery. So, you do have only one type of codes. By thoracotomy only, you have to get it removed. And that's why two codes depending on single lead and dual lead. So, 236 and 237. That was all about. It was still here. Till the code 238, you had all codes for pacemaker. In between, few codes I showed you, those can be used for pacemaker and defibrillator, but otherwise the codes were all for pacemaker. From the code 33240 onwards, you will see all codes are for defibrillator now. So defibrillator, always again, you have to check the same things. What type of defibrillator, what they are doing with the defibrillator, and based on that, you assign the codes. The first three codes in here, 33240, 230, 231. These are the codes for insertion of battery for defibrillator. Okay. Only batteries, not the entire device. Only batteries when I'm going to insert for defibrillator, depending on single lead, dual lead or multi-lead, I choose one code, either 240, 230 or 231. After this, the next code, 33241, if you see, it is for removal of the battery. First three codes were for insertion. The next code, 241, is for the removal of the battery. So when you are going to get the battery removed, you can use this code. The next three codes, 33262, 263 and 264. These are the codes for replacement of the battery. First three codes for insertion, the next code for removal, and the next three codes now 262, 63 and 64 for replacement of the battery. When I'm going to take out the old one and replace with the new one, I use one of these codes depending on single lead, dual lead or multi-lead. These were all the codes for batteries of the defibrillator. Now coming to the electrodes. The next two codes 33243 and 244. These two codes are for removal of the electrodes. If you remove the electrodes of the defibrillator, one of the codes you use. 243 is for the removal by thoracotomy. And 244, if you do a transvenous extraction of the electrode, then you use this code. So these two codes for defibrillator removal of electrode. Next code 33249. It is the code for the insertion of the entire defibrillator. When I say entire device, it's the batteries as well as the electrodes when you insert it together. That too, when I'm inserting a transvenous defibrillator in the patient's body, then I use this code 33249. The next code 33270. It is again for insertion of the defibrillator, but the type of the device is subcutaneous defibrillator. When I'm inserting a subcutaneous defibrillator entirely, I use the code 33270. After that, the next three codes 33271, 72 and 73. These are for the subcutaneous defibrillator again. SICD. In short, subcutaneous defibrillator is called as SICD. So for SICD, any electrode is inserted, 271. If the electrode is removed, 272. And if the electrode is repositioned, 273. All are for SICD 71, 72 and 73 depending on you insert the electrodes, remove the electrodes or reposition the electrodes, one of the codes you assign. Coming to the last code, last two codes in the section, that is 33274 and 275. These codes are for now pacemaker again. So far we were checking the codes for defibrillator. Now last two codes are for pacemaker again. These are for the type of the pacemaker, that is leadless pacemaker. If my patient has got a leadless pacemaker, then for the insertion of the leadless pacemaker 274 and for removal 275. What do you do with the pacemaker? Check and assign the code. So that was all about the pacemakers and defibrillators. Many times you get question on this part under cardiovascular system. From cardiovascular system, you are going to have only 3 questions in the exam. This is very long topic, but you will face only 3 questions. Okay. So mostly out of these 3 questions, you will have 1 questions based on pacemaker and defibrillator. What I'll do is I'll put a few questions related to only this part and then we will go on with the next. What you can do is do these first 3 questions. Do these first 3 questions, then we will go on to the next one. Question number 3 will need 3 codes, okay? Three codes, 3 codes for number. Nice. The first one, I think everyone is getting right. Second, also, whoever has answered, it's right.
Good question. Since we don't approach, is it like transvenous or cardiac? Shouldn't we go the approach?
Of For question number 3, whenever nothing is mentioned about the type of pacemaker, by default, take it as transvenous. Be it pacemaker or defibrillator, if it is not listed into the question, the commonest type is transvenous. So take it as transvenous. And as you could see, dual chamber pacemaker will always be transvenous. It cannot be epicardial, it cannot be leadless. Okay. Epicardial is you place over the surface of the heart, not inside the chambers of the heart. And leadless is only in one compartment. You are going to place that all the batteries and electrodes. So it's leadless. So it cannot be leadless also. Timsha, Varda, all of you, those who have answered question number 1 and 2, it's right. Go on with question number 3. Question number 3 is going to need 3 codes. Whatever I just explained, try to memorize everything and try to code it. So I'll give you a hint for question number 3. Question number 3, the patient is presenting for a replacement of permanent dual chamber pacemaker. What they are doing? Replacing the pacemaker. So when they are saying replacement of pacemaker, entire device they are replacing, and we don't have one single code for replacement of the device. So what we do, whatever old device is there, we code for removal of that device, and then we code for the insertion of the new device. Okay, so for removal of entire device, you don't have one code. So you code for removal of electrode, and then you code for removal of battery. So now I have removed everything. Then I code for insertion of the new device.
To answer clearly.
Mhm.
Question number 3. 33235, 33208, and 33.
225, I think, is not correct. 228, fine. And
33228.
double two.
33228.
It should be 33208. Last code. Not 228. 228.
Right. For the so one of the codes is 33208.
Yeah.
The other is 33228. Or the battery generator.
Removal. Yeah. One code will be there. Yeah, that. Your two codes are correct.
The two codes for
Two codes are correct. One code is incorrect in that, whatever you just mentioned. Is it done? Abdul, one code is correct. Actually, two codes are correct, one is not.
Okay, I will check the one.
Let me also check. I am not sure these numbers. 233, 23, or maybe correct. Yeah, Rimsha, for you also. Neetu, first and second, you have got it right. Just I'll wait for another 2 minutes. Just try and solve the question number 3 and we will go on.
the videos another part for the third question.
Is it done? I'll just share the correct answers, okay? Here, question number 1, relocation of the pacemaker pocket. So, pacemaker skin pocket, you have to code for the relocation of the pocket, and there is a separate code available for the replacement of that pocket, skin pocket. The correct code is 33222. 33222. This is the correct code. Most of you have got it right only. Coming to question number 2. Question number 2, it is for replacement of battery for dual chamber pacemaker. So, what they are doing? Replacing what? Only batteries. Only batteries are being replaced for which pacemaker? Dual chamber pacemaker. So, it's basically when dual chamber, it's going to be a transvenous pacemaker. So, you have a separate code available for replacement of batteries. You go to that code range for replacement of battery. 228 is the correct code. 33228 is the correct code for replacement of dual chamber pacemaker battery. Coming to question number 3. Question number 3, it is for the replacement of pacemaker, entire device. And as I told you that you don't have a direct code for replacement of entire device. You code for removal of the parts of the device first, and then you code for the insertion of the new one. So, what is the code for removal of battery of the pacemaker? The code for removal of the batteries is 3333. After that, I will remove the electrodes. So, for removal of the electrodes, I do have a code 33235. And then I code for the insertion of the entire device. The code is 33208. If you do not know that you need to use 3 codes, if you just go and check the code 33208, below that you will find a note. If you have to code for replacement of the device, then you can follow that note and you can use your codes in combination which are mentioned in the note. Okay, so below the code 208, you will find one note for replacement of pacemaker. If it's replacement of defibrillator, similar way it is. So for replacement of defibrillator, the note is written below the code 33249. Below the code 33249, you will find the note for replacement of defibrillator. And below the code 33272 also, you will find a note for replacement of defibrillator. Okay. Depending on the type of defibrillators, you do have different notes. Any doubts so far? No? Okay. So we move on to the next part. So we just completed pacemakers and defibrillators. Coming to the next procedure on the heart and pericardium, that is phrenic nerve stimulation system. Phrenic nerve, if you know, this is the nerve connected to the heart. We already discussed the codes into nervous system. There also we have discussed about neurostimulators, if you remember. Same guidelines are applicable here also. Only into nervous system, you do have codes for the neurostimulators related to all different nerves in the body except phrenic nerve. The phrenic nerve related codes are listed under cardiovascular system because this is the nerve which is just related to your heart, and that's why all the codes for neurostimulator for phrenic nerve are listed in here. So I'll not go into the guidelines again because the neurostimulator guidelines we have already discussed. So you have to check what they do with the neurostimulator. They insert, remove, replace, or they are dealing with some part of the device or with the entire device, or repositioning is being done. Whatever it is done, you do have all different codes, and we have already discussed the guidelines along with nervous system. Next, you have electrophysiologic operative procedure. When your patient is undergoing this electrophysiologic operative procedure, this procedure is sometimes also called as a maze procedure. For coding this procedure, you just have to remember 2 things. One, this procedure can be either limited or extensive. How do you know what is limited and what is extensive? The definitions are given on that same page. If you just check page number 245. Below this electrophysiologic operative procedures, you do have what is called as limited and what is called as extensive. The definition is given. You will read through the definitions. You will match with your patient's record. Wherever it will match, you will decide. So first decide whether the procedure is limited or extensive. Secondly, you are going to check is whether that procedure was done with cardiopulmonary bypass or without cardiopulmonary bypass. I already told you when you perform cardiac procedures, you cannot keep your heart up and running and do the procedure, but sometimes you can. So this particular procedure, you can do it when your heart is functional. It's beating, still you can perform the procedure. Usually limited procedures you can do when your heart is beating. But when it's an extensive procedure, you need to stop the heart and you perform the procedure, then you restart the heart. So if you are using that device, cardiopulmonary bypass device is being used when you stop your heart, then you call that procedure with cardiopulmonary bypass. If you are keeping your heart functional, you are not using that device, then you call the procedure is without cardiopulmonary bypass. Whenever you are going to code, always check it is with or without cardiopulmonary bypass. So only 2 things you will check, whether the procedure is limited or extensive, and was it with or without the cardiopulmonary bypass, and then you can assign the codes. Otherwise, the codes are self-explanatory. You just read the description, match with your patient's record, and assign the code. I'll not go into the details because there are no specific guidelines. Next, you do have the procedure that is subcutaneous cardiac rhythm monitor or hemodynamic monitors. These are certain devices. Again, these are the monitors, which like we just saw, pacemakers, defibrillators. So whenever any device, you need to the body. So what do you do with the device? You insert it, you remove it, you repair it, you replace it, you reposition it. What you do with the device, you check that. And which device you are dealing with, that also I asked you to check. So if it's a cardiac rhythm monitor or hemodynamic monitor, you come down to this code range, check what they do with the device. Based on that, you assign the codes. It's similar to what pacemakers and defibrillators, which we discussed. After this hemodynamic monitors, the next is heart and great vessels. So that was till here. It was the first part of the chapter. Heart and pericardium. We were discussing heart and pericardium. Now we are going to discuss heart and great vessels. So the internal structures into your heart and the great vessels, basically all those vessels directly connected to your heart. Your superior, inferior vena cava, pulmonary artery, pulmonary veins, and aorta. So any procedures performed on the internal structures of the heart or these vessels, the codes will be listed here. In the beginning, they have certain general codes for a repair of the cardiac wounds or certain exploratory procedures on the heart are being done. Then all these codes are listed in the beginning. These are certain general codes. They do not have guidelines. Coming to the next procedure regarding cardiac valves. Cardiac valves, there are four types of valves inside the heart. That is, you have aortic valve, pulmonary valve, then you have got mitral valve and tricuspid valve. So which valve you are going to operate on, that first check that. Whichever valve is not functional, it's damaged, only for that particular valve you will perform the procedure. So which is that valve? Check it. Second thing you will check it is the approach of the doctor. Remember, with musculoskeletal system, with nervous system, I told you approach meaning how the doctor is going to reach out to that surgical area. When I have to reach out to the surgical area, I need to cut open the patient for this musculoskeletal surgeries or neurosurgeries. But for cardiac surgeries, I can do it as a closed procedure also. If I need to operate on the cardiac valves, then I push the catheter or my devices through the vessel. Some vessel I will choose. Through that vessel, I push the device and I operate. I take the vessels into the heart, and then I'm going to operate on the cardiac valves. So what was the approach? Through which vessel I have pushed my surgical devices, or if I have done an open surgery. You have to check that, and based on that, you can assign the codes. So that is the second thing you will check, the approach of the physician. And lastly, you have to check now cardiac valves when these are damaged. Some valves I just can repair. Repair as in whatever the damage has happened, I will just go ahead and repair it. But sometimes the damage is beyond repair. Then I just have to remove the damaged valve and insert a prosthetic valve instead there. So an artificial valve is inserted, but it's not possible with every valve. So you just can replace the old valve with the prosthetic one for only few of them. Like replacement is possible with aortic valve or pulmonary valve, but not with tricuspid or mitral valve. So you have to always check which valve I am dealing with. For each valve, there are separate code ranges they have mentioned. After that, you will check the approach of the doctor and then check whether replacement is done or repair is performed for the existing valve. And based on that, you assign the codes. First, you have this aortic valve listed. Under aortic valve, can you see? Transcatheter aortic valve replacement. I can replace the valve with the new prosthetic valve if it's a aortic valve. So it's called as a TAVR or TAVI procedure. Both are same. That is implantation of the new prosthetic valve or replacement of the existing valve. That is the same thing. That is, it is either called as TAVR or TAVI procedure. That is possible, but I cannot repair the existing valve for aortic valve. And then if you go down to the codes, if you check the codes, with every code they mention the approach, like the code 33361. This is the code for this TAVR or TAVI procedure with prosthetic valve percutaneous femoral artery approach. So I am going to reach out to this aortic valve through femoral artery. It can be either open or closed procedure. So always check, was it closed or open procedure? What was the approach of the doctor? And all depend on the approach of the doctor. You do have different codes listed there. That is what is you match and you choose your code. That was for aortic valve. Same way for the mitral valve. Mitral valve, if you go to transcatheter mitral valve repair. Mitral valve, you can only repair, you cannot replace with the prosthetic valve. So here TMVR procedure is possible. Along with the TMVR, again for the codes, you have to check the approach of the doctor, whether it is open surgery, closed surgery. Based on that, you assign the codes. Then you have tricuspid valves, different code ranges mentioned. So it is TTVI procedure, that is implantation. You can replace this tricuspid valve with the new one. Okay. New prosthetic valve, or here repair also is possible. So tricuspid valve repair also you can do, and it is called as TTVR procedure. And again, you check the approach and you assign the codes. Lastly, pulmonary valve. So for pulmonary valve, whatever you can do, you check and you assign the codes. The codes will be all similar for all the valves. After the valves, you have the codes for coronary artery. Now, coronary artery, it is again a great vessel. It is a artery connected to your heart directly, because this is the artery supplying blood to your heart. Any anomaly into the coronary artery. Earlier also, during your anatomy physiology class, I might have mentioned coronary artery has got two major branches, right and left coronary. And then left coronary further divides into two branches, that is left anterior descending and left circumflex. So usually there will be three major branches to the coronary. Sometimes, like by birth, there is a defect, one branch is missing, or there is connection between two branches of the coronary or something like that, then I have to repair it, because this is the artery supplying blood to your heart muscles. If the heart muscles are devoid of blood supply, then obviously the patient is going to land into myocardial infarction and death. So I just have to repair whatever the anomaly is. Depending on the anomaly, treatment will change. So say one branch is missing. What I have to do? I have to create that branch of the coronary. How do I create? By using a graft. I will take up some healthy vessel from somewhere into the body. I cut open the patient's chest and I create one branch there. Or say there is abnormal connection between two branches. What do I have to do? I just have to remove that connection, cut that connection and close it. So whatever is the anomaly, depending on the anomaly, the treatment will keep on changing. What is the anomaly? First check, then try and check how they treated it, match that and use your codes. The codes will be simple. That was for coronary artery anomaly. Then you have the codes for this endoscopy. I'll come back to these two codes later on. Just mark them for now. Going to the next procedure. That is venous grafting only for coronary artery bypass. You must have heard of the procedure, that is bypass grafting procedure, or bypass surgery, usually they call in the layman's words. So what is this bypass surgery? Just now I said to you that your coronary artery has got two major branches, right and left coronary is there, and this left coronary further is divided into two more branches. Okay, so this left coronary, when it divides into two major branches, it is left anterior descending and left circumflex. Say my patient has got a blockage into the coronary artery. Whatever the branches, in one of the branches there is a blockage. Blockage can be because of any reason. It can be a thrombus, it can be a embolus, it can be aderoma, that is fat deposition inside the vessel. So once that blockage is there, I need to open it immediately. Otherwise, cardiac muscles will be devoid of oxygen. So when I am going to open it, I do have different procedures to open it. I can perform, if it's thrombus, I will do thrombectomy. If it's embolus, I will do embolectomy. Or like it's aderoma, then I can perform angioplasty or stent placement, atherectomy. These are different procedures which I can perform and get it removed. But certain times this is not possible. By all this means, whatever I try, the blockage is not getting opened, then what do I do? The last major is doing a bypass surgery. In bypass surgery, what you are going to do is you are not going to touch that blockage. Wherever the blockage is, let it be, and you create another route for the blood to flow. When you create that other route, you need a graft. So you are going to take up a healthy vessel from patient's body, from some other body part, and you graft that vessel into the coronary artery. And this procedure, you call it as bypass grafting. Whenever I am performing bypass grafting, first I need to operate on the patient, take out that healthy vessel. That is another procedure. But this procurement or harvesting of the vessel is a part of your bypass grafting. This bypass grafting is called as CABG procedure, in short, cabbage procedure, coronary artery bypass grafting. They call it as cabbage or CABG procedure. During this procedure, when I'm harvesting a graft, that harvesting of the graft is a part of the code. When I code with CABG, it's all included in there. Do not code harvesting of the vessel separately. When you are coding for this grafting, check whether they used artery as a grafting material or vein as a grafting material, because I do have options. There are two types of vessels in the body, arteries and veins. If I'm using artery as a grafting material, then it's called as a arterial grafting. When I'm using vein as a grafting material, it is called as a venous grafting. But sometimes, say there are multiple blockages. Like my patient has got a blockage into different parts or different vessels, 2, 3 places, there is a blockage. Okay, there are 2 more blockages here. So when I'm going to code or when I'm going to perform this CABG procedure, here say for these 2 blockages, I used vein as a grafting material, and here I have used this particular thing, I have used artery as a grafting material. So I am doing a combination of artery and vein. These different grafts are used for the CABG procedure, then I call it as a combined grafting. Okay, when both artery as well as venous grafts are used, then I call it as a combined grafting procedure. For combined grafting, different codes will be there. For arterial grafting, different codes will be there. If it's venous grafting only, different codes will be there. Whatever you see here now, below this, is it? Here, this section, venous grafting only. When the doctor is going to use only venous grafts, no artery is used, only vein is used as a grafting material, then you are going to choose the codes from this section, venous grafting only. Check how many grafts they applied. 1 graft, 2 grafts, 3 grafts. How many venous grafts are applied? Based on the number of grafts, you choose your code. That was venous grafting only. If you go further down and check, go on page number directly 255. Page number 255, you have the next section, arterial grafting for coronary artery bypass. So if I am using artery for grafting, then I can use the codes listed in this section, arterial grafting. So again, depending on the number of grafts, how many grafts I have applied, 1 graft, 2, 3, 4. How many grafts I have applied, arterial grafts, I check. And by matching the number of grafts, I choose one code. Now when it is only arterial grafting or venous grafting, 2 different sections are there, I use it. When it is combined grafting, for combined grafting, the arterial part of the combined grafting, I code it from here itself. This arterial grafting part, from here, I will code those arterial grafts. How many arterial grafts are used? I will check based on the number of arterial grafts. I will use one code from arterial grafting section for the combined grafting. And now the venous part of this combined grafting, when I have to code it, you go to the previous part. Which part I left? This part. Combined arterial venous grafting section. Okay. So you'll go to this section of combined arterial venous grafting. So the venous part of that combined grafting, you code it from here. If you see the codes listed under that combined grafting section, those are all add-on codes. Every code is an add-on code. Why? Because you cannot use those codes alone. When it's a combined grafting, you code arterial grafting first. Along with the arterial grafting, the venous part of that combined grafting, you code it by using this add-on codes from the combined section. So check how many venous grafts are applied, and based on the number of venous grafts, you use one of these add-on codes for that combined grafting. When it's combined grafting, the venous part of the combined grafting, do not code from this previous section of venous grafting only. It says venous grafting only. Only word is very important. When it's only veins are being used for grafting purpose, then only you use the codes from here. If it's combined grafting, the venous part of that combined grafting, you have to code it from combined arterial venous grafts. Okay. Now, as you coded everything, say when the doctor is going to harvest the vessels, I told you that harvesting of the vessels is all included into the CABG procedure. So you are not going to code for the harvesting of the vessels, but there are exceptions to that rule. So if you go on page number 255, page number 255, arterial grafting, third paragraph, fifth line. 255 page number, third paragraph, fifth line, if you check, they have given these exceptions. Whenever you are going to harvest a upper extremity artery, you have to report it separately by using the code 33509 or 35600. To report harvesting of an upper extremity vein, the exception you have, this is again exception, you have to code separately. So the code which you use is 35500 in addition to bypass procedure. And to report the harvesting of femoropopliteal vein segment, you have to report it separately again with the code 35572. These all codes are add-on codes. Whatever I have highlighted here, these codes are add-on codes. They will come into the later part of the same chapter. But for now, you can highlight it. So whenever they are using femoropopliteal vein, or they use upper extremity artery or upper extremity vein for grafting purpose, then harvesting of these vessels, you code it separately. Okay. Otherwise, if any other vessel apart from these three vessels, any other vessel is used for grafting purpose, harvesting of those vessels, you will not code separately. Fine. Whatever codes we just discussed, these are for open procedure. Whenever you are performing this harvesting of the vessels by open method, then you don't code that harvesting. But if any vessel I am taking by an endoscopic approach, then you have to code it separately. And for endoscopic harvesting of the vessel, I left the previous part. If you remember, I asked you to highlight those codes on page number 253. 253, there is a separate section endoscopy. So you go to that endoscopy. There are two codes there. One is for the endoscopic harvesting of a vein. If I harvest any vein by endoscopic method, then I code with 33508. And if I am going to harvest any artery by endoscopic method, then I code with 33509. In addition to CABG procedure, you have to use these codes. These are add-on codes for the endoscopic harvesting of the vessels. Okay. So always remember, when you are coding for CABG procedure, check whether it is only venous grafting or only arterial grafting or it's combined grafting. If venous grafting, separate section. If arterial grafting, separate section. But if it's combined grafting, then you code the arterial part of the combined grafting from arterial section, and the venous part of that combined grafting you code from the combined section. And then further, you have to check which vessels are harvested. Any of the exception vessels are there, you code the harvesting of those vessels separately, like femoropopliteal vein or upper extremity artery or vein harvested, code it separately. And whatever this harvesting, if it is done by open method, no issues. But if it is done by endoscopic method, then use one more additional code for endoscopic harvesting of the vessel. So that is how you will use your codes. That was all for CABG multiple codes. Any doubts? No?
No, ma'am.
We will practice few questions related to this CABG procedure, and then we will go on to the next part. Okay. Okay. You can do question number 6 and 7. For now, do this question number 6 and 7. This is all related to CABG procedure, cabbage procedure, which we just discussed. Assign the codes and then we will go on. Question number 7 is going to need 5 codes. Okay. Done. Is it done? First one, I think all of you have got right. Sixth one, that is. Neetu, one more code is needed. When you are assigning the codes for question number 7, remember you better not assign the add-on code in first place. Okay? There are no sequencing rules, but do not assign any add-on code in first place.
Ma'am,
Yes,
is it 35500 the one more code?
I need to check, Neetu.
Yeah.
Because I also do not remember all the codes, okay?
Okay.
Yeah, we'll check together. Is it done? Everyone? Another 2 minutes, I'll wait and then I'll discuss the answers, okay? Can you share the answers now? Is it done? Let's check it together. Okay, question number 6. All of you have got it right. This is for the coronary artery bypass graft using 4 venous grafts. So they are performing coronary artery bypass grafts means cabbage procedure, CABG procedure they are doing by using 4 venous grafts. So only venous grafts are used. So how many venous grafts are used? 4. You have to match the number. You have to go to that venous grafting section, match the number, choose the code. 33513 is the correct code. Coming to question number 7. Question number 7, again, the patient underwent cabbage procedure by using 3 venous and 2 arterial grafts. So when venous and arterial grafts are used together, it's a combined procedure. The combined procedure, when I code, the arterial part of the combined procedure, I coded by using the arterial grafting section as usual. So the code for the 2 arterial grafts is 33534. Okay, that is my first code. Then I go to venous grafting. So this is the combined procedure. The venous part of this combined grafting, I have to code from the combined arteriovenous grafting section. There I go. Then I choose the code for 3 venous grafts from there. And that will be a add-on code 33519 for 3 venous grafts. After this code, further when I read the description, what they have mentioned, for grafting, saphenous vein, femoropopliteal vein and radial artery were used. So the harvesting of these vessels was done. Saphenous vein, is it into exception? You have to check where the saphenous vein is located. Is it a vein of upper extremity? Check. No. It's a vein of lower extremity, so it's not into exception. Leave it. You don't have to code for the harvesting of saphenous vein. Then check whether femoropopliteal vein is into exception. Yes. The femoropopliteal vein harvesting is into exception. So I just have to code for harvesting of this femoropopliteal vein separately. The code for that is 35572. Once I code that, then I go to radial artery. So I have to check again radial artery. Is it the artery of upper extremity or not? I have to check. If you go ahead and check, radial artery is located into upper extremity. So the harvesting of radial artery, you have to code separately. The code for that will be 35600. And then further when you read, the venous grafts the doctor has procured by endoscopic harvest. Any graft when it is endoscopically harvested, you use a separate code, that is 33508 will be another code. Doubts? All of you got the codes? No? For this question, anyone has got all the codes? No?
For artery stage harvesting, when it's anesthetic and not anesthetic, the code is separate.
Yes, yes.
I think when you said venous endoscopic, I had to ask you the days. But it's
Ah, yes, yes.
that's how it's-
Okay. Fine. So with this, you can take a break. Take 20 minutes break. Be back by 12:25. Enough. So come back by 12:25 and we will continue with the remaining part of this chapter. Are you all there?
Yeah, yes, ma'am.
So we'll start with the next procedure now. So starting from here onwards, you have got codes for cardiac anomalies. After the CABG procedure, from page number 256 onwards, you do have codes for cardiac anomalies. There are various different kinds of cardiac anomalies. So by birth, if there is a defect into the heart, so sometimes one cardiac chamber is missing, sometimes there is a connection between two chambers, or sometimes the vessels which you need to start, like the pulmonary artery, which should originate into right ventricle, aorta should originate into left ventricle, but these vessels originate in the opposite ventricle or opposite chambers. So that is transposition of the vessels, and various different cardiac anomalies could be there. Depending on the cardiac anomaly, you do have different treatments. When you are performing the treatment will depend on what is the basic defect. So if there is abnormal connection between two chambers, I need to close it. If there is one cardiac chamber missing, I need to create it. If there is transposition of the vessels, then I need to apply the grafts and just originate those vessels into the exact chambers where they should originate. Or whatever is the cardiac anomaly, depending on that, I have to change my treatment. So here you will see under this cardiac anomalies, they have listed the procedures based on the type of anomaly. So first they will list the anomaly. Whatever is the anomaly, depending on that, various treatments will be possible. So whatever possible treatments for that anomaly, those all procedure codes you will see under that particular anomaly. In the beginning, they have got this single ventricle or other complex cardiac anomalies. So if there are any ventricular anomalies, two ventricles are there, right and left, any ventricle has got any anomaly, then treating that anomaly, you have got codes listed in this first part. If you go further, you will see all different headings. So there is septal defect. So there are septums which are separating the different chambers. So any defect is there into the septum, then how you are going to treat it, based on that different procedures will be there which are listed in there. Then sinus of Valsalva, venous anomalies. So all different anomalies are listed one by one. You just have to go depending on the type of anomaly to that code range. Then you will match the procedure, how the doctor has treated it, and based on the type of procedure, you can assign the codes. No specific guidelines here. Okay, just you have to check what is written into the record, match with your code description, match the type of anomaly, go to that code range and start searching for your codes and assign the codes by matching. Then shunting procedure. So all these are the different procedures performed for different types of anomalies. Then transposition of the great vessel, it is another type of anomaly and everything. So truncus arteriosus, aortic anomalies. So all different anomalies are listed one by one. Go to the procedure code range, match with your patient's record and choose the code. After this cardiac anomalies, you do have the next procedure. That is hereafter. Now it starts for great vessels. We discussed one great vessel, coronary artery. The procedures related to coronary artery. Now it's thoracic aorta. Aorta originates into your heart. So the procedures performed on thoracic aorta will be listed hereafter. The first procedure listed is for the aneurysm. Aneurysm, I explained in the last class with nervous system that it's a dilatation of a vessel. Whenever there is a bulge into the vessel, you need to treat it. Otherwise, the vessel wall is like it is thin in that area, it is fragile and it can rupture and the internal bleeding can happen. So you have to treat it. So either you cut the portion, dilated portion and apply a graft there, or you apply this compression bands there, or you just apply some clips and other medical devices available. You can just use them and you can treat these aneurysms. Or if an aneurysm is located into thoracic aorta, the codes are listed here. But if the aneurysm is located somewhere else in the body, then depending on which vessel is affected by this aneurysm, based on that, the codes will be into different parts. So when we will go on to the third part of this particular chapter, all other vessels apart from great vessels, other vessels are listed in the third part of the chapter, where you will have codes in the descending order. So after this thoracic aorta, when we go to third part, you will see for abdominal aorta, then for infrarenal aorta, then for common iliac arteries, and then for other different vessels in the body. all normal minor arteries and veins. For that, the same procedure will be repeated. So this is for thoracic aortic aneurysm. Check how they treat it. Based on the treatment, you assign the codes. This is only for the thoracic part of aorta. Next, you have endovascular repair of thoracic aorta. Last class, I explained to you that endovascular repair, when they use this word endovascular repair, it can be thrombectomy, embolectomy, angioplasty, stent placement, atherectomy, or any procedure which is performed to open up the blockage into the vessel. Those all vessels together are called as endovascular repair procedures when you do them as closed procedure. If you are going to cut open the patient, it's no more endovascular. It is it's an open procedure basically. Endovascular is inside the vessel, any repair is performed. So all these procedures, whatever I just mentioned, first check when they are like there is a blockage into a thoracic part of aorta or some damage into the thoracic part of the aorta. I need to repair it. I have to check what procedure I am going to do. Was it thrombectomy, embolectomy, angioplasty? What I am going to do, just check that. And then you can assign the codes based on the type of the procedure. They can perform one procedure at a time or they can do combination of the procedures. Maybe I'm doing angioplasty along with stent placement or angioplasty along with atherectomy. So I can do like multiple procedures together or one single procedure at a time. If 2-3 procedures are performed together, there are combination codes available. Combination codes meaning I can code all the procedures by using a single code. So check that combination of procedure, that same code with the same description of those procedures is available. Then you go ahead and use the combination code. In this area, you will see all your codes are very much descriptive. A paragraph long description for every code you will find in. So you have to match that entire description with your patient's record and you have to assign the codes. Otherwise, the guidelines, there are specific guidelines, but those guidelines we will check into the last part. As I said, for every part of aorta, different set of codes are listed. This is for thoracic part, then for abdominal, infrarenal, and then for common iliac arteries. When we will go to common iliac arteries, there I'll explain the entire guidelines, okay? So here, for now, you just can remember this. This is for the thoracic part of the aorta. Any of the endovascular procedures are done, then the codes are self-explanatory. Match your description with the code description and assign the code. Then you have got endovascular repair of congenital and vascular defects. Earlier we saw there was a section for cardiac anomalies. Whenever by birth there is a defect into the heart and you are going to treat it, the codes were listed under cardiac anomaly section. If there is any other defect or any defect, cardiac defect, which is treated by endovascular repair, not by some other procedure, but endovascular repair is the method of treatment, then all codes are listed here. So whatever kind of cardiac anomaly it is, if you are treating it by endovascular repair, the codes will be listed into this section and not in the previous cardiac anomaly section. So that is all about the cardiac defects. Coming to the next great vessel, that is pulmonary artery. So pulmonary artery also originates into your heart. Whenever you are performing any procedure on the pulmonary artery, all procedures are listed here. So whatever procedure it is, embolectomy, thrombectomy, angioplasty, or maybe you are applying a graft or you are just treating the vessel by any other method, all the different repair codes are listed here related to pulmonary artery under the pulmonary artery section. That was all about the great vessels. Now coming to heart and lung transplant. So we are checking the section that is heart and great vessels. So heart transplant related to heart now. We have seen other organ transplants earlier. That is your kidney transplant, liver, or maybe pancreatic transplant or any other organ transplant is performed. Always it is done into 3 steps. First, you perform the procedure on the donor, then the backbench preparation work, and finally, you are going to transplant the organ into the recipient. When I am going to code for this procedure, that is heart or lung transplant, there is a separate topic, separate chapter, respiratory system. Lung transplant codes mostly listed under respiratory system. But if I'm going to do heart transplant along with lung transplant, here you will find few combination codes. That is for both the procedures together. So use those combination codes whenever possible. But if it is not possible to code it together, then you have to code it separately for heart transplant and for lung transplant, a separate code from the respiratory system. Heart transplant, you will never ever have a living donor for heart transplant. Always it should be a cadaver donor, a dead person. But for lung transplant, you can have a living donor. Living donor can donate 1 or 2 lobes of his lung, not more than that. You cannot donate entire lung, but 1 or 2 lobes you can donate, always a living donor. But cadaver donor can donate the entire lung. So if it's heart and lung transplant done together and the organs are procured from different donors, like heart I have taken from the cadaver donor and lung I have taken from a living donor, maybe a relative or so on. So always check the donor procedure. There are combination codes available, but do not use combination codes if your donors are separate. Okay, if one like lung donor is separate person and a heart donor is a separate person, then do not code it together, code it separately. So all these codes are there. Always you have to check which step of the transplant they are asking you to code, whether the procedure on the donor, procedure on the recipient, or the backbench preparation work they are asking you to code. Based on that, you have to assign the code. All codes are separate codes. That was all about heart and lung transplant. Coming to the next procedure, that is extracorporeal membrane oxygenation or extracorporeal life support service. In short, it is called as ECMO or ECLS. This particular procedure, like the name suggests, corpus is your body. Extracorporeal is outside the body. What is happening outside the body? Oxygenation. Whenever the patient is suffering from severe cardiac or lung condition, the oxygenation of the blood will not happen properly. So all your organs need oxygen supply, proper oxygen supply for their functioning. So what you do, you just put your patient on a device. The device is taking care of the oxygenation of the blood. Here, when you are going to put your patient on the device, this ECMO device, it's not just you connect the device to the patient's body. For that, before, you have to perform a minor surgical procedure. In that surgical procedure, you insert shunt into the patient's body, or you call it as a cannula. A small catheter is inserted through that catheter. So once you can insert the catheter, the blood will be taken out of the body through the catheter. It is going to pass through the device. So the device is going to oxygenate the blood. Once the oxygenation of the blood has happened, this oxygenated blood is put back into the patient. So your heart and lungs don't have to worry that circulation of the blood. If the heart is weak, the circulation is taken care of by this device. And if the lungs are weak, then the oxygenation also is taken care by this device. For this, I said as a cannula is inserted, the cannulas are of two types. You can have a veno-venous cannula or a veno-arterial cannula. If it's a veno-venous cannula, means you insert only one cannula into patient's body, and when you insert only one cannula, it is going to support only the function of one organ, that is lungs. So that is only with the veno-venous cannula, you can support the function of lungs. But if you insert a veno-arterial cannula, you are going to insert two cannulas. And once these cannulas are in place, and if you connect the patient, then the function of heart and lung will be taken over by the device. So depending on which cannula you are going to use, which organ you are going to bypass. So if it's veno-venous cannula, only lungs it will support to. If you use a veno-arterial cannula, it will support both the organs, lungs and heart. Now, as you have inserted the cannula, once you insert the cannula, you need to connect this to the device. When you are connecting, as heart and lungs are vital organs, if something goes wrong during the connection, the patient is immediately going to die. So you have to have a professional person, a provider who is a qualified person to just connect this to the patient. That is, this procedure, when you connect, it is called as initiation. And once you initiate the patient on ECMO, you need to monitor the patient 24 by 7. Because if this device somehow goes wrong or some complications in the device, the patient will immediately die. So you have to have the monitoring done for the patient 24 by 7. So for this monitoring, you will have separate codes. First is the code for initiation. When I initiate the patient, when I initiate the patient, the monitoring of that day is included when I assign the initiation code. So I will not assign any monitoring code for that day. But the second day onwards, say my patient is on ECMO for 3 days, 4 days, 5 days. So first day I will not, when I initiate, I will not use any monitoring code. But second day onwards, I have to start using a monitoring code. For each day, I keep on assigning a monitoring code. And for the cannula also, you will have separate codes. So when I insert the cannula, say my patient is now on ECMO, but now he is doing fine. His organs are doing fine. So I need to remove. So I need to disconnect the device. So when I'm going to disconnect, I need to remove the cannulas also because I don't need them anymore. So the removal of the cannula has to be performed later on. So you will have separate codes for the procedures on the cannula. What I do with the cannula, insert it, remove it, reposition it, repair it. What I do with the cannula, separate codes will be there. Separate codes for initiation and separate codes for monitoring. So you in all can assign 3 codes. If you want to code the entire procedure, you can assign 3 codes. One for the insertion of the cannula, then for initiation, and then for daily monitoring. So here, if you go down, you will see your code starting from the code 33946 and 947. These 2 codes are together. These 2 codes are for initiation. When I initiate the person on ECMO, I can use one of the codes depending on which cannula is used. If I'm using veno-venous cannula to connect, then 946 is the code. If it's veno-arterial cannula, 947 is the code. The next 2 codes, 948 and 949. 33948 and 949. These are for the daily management. Like I said, monitoring is required. So, what cannula I have connected to, based on that, the daily management codes also are different. So, 948 is when it's a veno-venous cannula, and 949 is for veno-arterial cannula. Starting from the code 33951. From 951 till 956. All these codes are for the insertion of the cannula. When I'm going to insert the cannula, you have to check different things like what is the age of the patient, then which cannula is being inserted, and then you have to check how it is inserted by open procedure, closed procedure, how they insert it. So all 3 things you have to match whenever you code any procedure on the cannula. You have to check first what they do with the cannula. Insertion, removal, repair, what is being done. Then check the age of the patient and check how they do it by closed method or by open method, how they do it. Based on that, you assign the codes. These all codes are for insertion till 956. From the code 339957. From 957 till 964. All these codes are for the repositioning of the cannula. If I need to reposition the cannula, then I use one of these codes, again depending on the age of the patient and how do I do it, by endoscopic method, by open method, and so on. You assign the codes. Next, starting from the code 33965 onwards, all these codes are for the removal of the cannula. So if I need to remove the cannula, all these different codes are there for removal. That was all for ECMO. Coming to the next procedure, that is cardiac assist device. So what is cardiac assist device? It is again another device like pacemakers, defibrillators, or we just saw hemodynamic monitors, cardiac assist monitors, and so on. So that is similar way. It is a cardiac assist device. So cardiac assist device, when you are going to code, whatever guidelines I described for pacemakers and defibrillators, same guidelines applied here. You have to check first which is the device. Then you have to check that for cardiac assist device, you have to consider what they are doing with the device. Inserting the device, removing it, repairing it, or replacing some part of the device, this device also comes up with two parts. There will be one battery, and instead of leads, like pacemaker has leads, a cardiac assist device will have a pump. Pacemaker defibrillators you use whenever the electrical conducting system of the heart is not functioning properly. Cardiac assist device you will use whenever your cardiac muscles are weak. Electrical conducting system is all fine, but cardiac muscles are not generating enough force to push the blood. So cardiac muscles are weak, they are not contracting enough. Then you use a cardiac assist device so that this device has a pump. The pumping action of the heart, for that this device is used, and that's why it has two parts, a battery and a pump. This device you can have entirely inside the body, or sometimes you can have it outside the body also. So based on that, the device is classified as intracorporeal or extracorporeal. So one additional thing, apart from checking what they do with the device, you have to check an additional thing whether the device is intracorporeal or extracorporeal, and based on that you assign the codes. First of all, check what they do with the device, insertion, removal, repair, or repositioning, and then check with entire device the doctor is dealing with or only with the part of the device, and further check whether the device was intracorporeal, extracorporeal, and you assign your codes. The codes and the guidelines are very similar to pacemakers, so I will not go into the details again. Coming to the last part of the chapter. So far, we were checking the codes into the second part of the chapter, that is heart and great vessels. First part was heart and pericardium. Second part was heart and great vessels. Now coming to the third part, that is arteries and veins. This part of the chapter is going to deal with other vessels in the body which are not directly related to heart. So your abdominal aorta, infrarenal aorta, or the different arteries and veins in the body, for that you will have codes listed here. The very first procedure under arteries and veins which is listed is embolectomy and thrombectomy. I have already explained the procedure. Removal of embolus is called as embolectomy. Removal of thrombus is called as thrombectomy. So whenever these procedures are done, which procedure is done, you have to check. And then based on that, you are going to assign the codes. The codes will be location specific. Location as in which artery I am treating. By doing this procedure, which artery I am going to treat, or vessel, or maybe artery, vein, whatever it is, which vessel I am going to treat. I need to know the name of the vessel, and based on the name or based on the part of the vessel, you are going to assign the codes. The codes are simple, simply based on the location. Coming to venous reconstruction. So reconstruction of the vessel, whenever the vessels are damaged and you need to reconstruct them. Like say in an accidental injury, the vessel is damaged, or basically when accidental injury is there, you call it as repair. Okay, reconstruction is there is some anomaly into the vessel, some abnormal connections are there or some anomaly is there, and I'm going to treat it. I will code it from the range that is reconstruction. But if there is accidental injury, the vessel is completely damaged, crushed, or I need to apply a graft in there, then I code it from the section called repair section. Okay, so there is venous reconstruction and then there is endovascular repair again. But this endovascular repair, now if you see, it is for abdominal part of the aorta. Earlier, we just saw the same procedure for thoracic part of the aorta. Same guidelines are applicable here for abdominal part of the aorta. So we skip this part. Then you will see same procedure, endovascular repair for infrarenal aorta also. So if you go down on page number 280. Page number 280, you will again see the same procedure. Endovascular repair, but this is now for visceral or infrarenal part of the aorta. And then again, there will be another section for iliac arteries. There I'll explain the detailed guidelines. Okay, for now we are going to move on. So that was endovascular repair. After endovascular repair, the next procedure listed is direct repair of aneurysm. We earlier saw the repair of aneurysm, but that was for thoracic part of the aorta because it is listed under great vessel. Now this is for all different vessels in the body. Okay, whatever any other artery or vein that has got an aneurysm, Then if I am going to treat it, similar methods will be there. I apply a graft, I apply a compression device, or I apply some clips and so on. So which vessel basically the aneurysm is located into? I just have to check that. Based on the location, I have to assign the codes. When it was thoracic and aneurysm, only thoracic aorta is affected. I know that. But now we are checking the part where all different arteries and vessels are listed. So here you have to know which vessel you are going to treat based on the name of the vessel. Different codes will be there. You keep assigning the code based on the location. That was for repair of aneurysm. Then you have got the codes for repair of arteriovenous fistula. Fistula is nothing but an abnormal connection between two body parts. Earlier, I said there cannot be any direct connection between an artery and a vein. Otherwise, there will be mixing of all oxygenated and deoxygenated blood. So, if at all there exists a abnormal connection between an artery and vein, I need to remove it. So, when I repair that, the codes will be listed here. So where that abnormal connection it is, between which two vessels the abnormal connection exists, you have to check that. And then based on the location, you assign the codes. Next, you have repair of blood vessels other than fistula with or without patch angioplasty. So apart from fistula, any other defect into the vessel is there and need to be repaired. Then again, based on the location, you assign the codes for repair. If it's fistula, separate code range is there. But if apart from fistula, any other repair, any other defect is there and I am going to repair it, the code range which I'll use is from here. That is repair of blood vessels. Again, the codes are based on location where that repair is performed. You have to check into which body part and then you assign the codes. Then coming to thromboendarterectomy. Okay. Thromboendarterectomy is, I told you, you cannot have a thrombus inside the vessel. Thrombus is a blood clot into the vessel. Inside your vessel, you cannot have blood clots. The clot will block the vessel and there will be lack of blood supply to the further part of the body. But sometimes I create a thrombus into the vessel to treat the patient. Like say patient is bleeding vigorously. There is an accidental injury, patient is bleeding. I could not stop the bleeding. So what I do is I create a thrombus at the end of the vessel so that the bleeding will stop. Similar way, I create an embolus also sometimes to treat the patient. So that is different procedure. We will see the codes later on. So whenever I am creating a thrombus to treat the patient, it's called as the thromboendarterectomy procedure and the codes will be listed here. So which vessel you are going to treat it by doing such procedure, you have to check based on the location you assign the codes. Next, you have angioscopy. Endoscopy of vessels is called as angioscopy and the code, one single code is there, that is an add-on code. Next, you have bypass graft. So bypass graft, we already saw coronary artery bypass grafting, cabbage procedure, where you apply the grafts into the coronary artery. But say not the coronary artery, I need to apply the graft somewhere else in the body. Some other place there is a blockage. Some other vessel is blocked apart from coronary artery. Any blood vessel supplying blood to brain or maybe supplying blood to kidneys or liver, any vessel is blocked. So I need to apply a graft in there so I can code it from here. So where I am going to apply the graft and which vessel I am going to use for as a grafting material, I have to check that and the different codes will be here. With cabbage procedure, all harvesting of the grafts is included. So we do not code separately. But when you apply the graft somewhere else, not into coronary artery, but somewhere else you apply the graft, then harvesting of the vessel you can code separately and application of the graft also you can code separately. All these codes will be listed into this part, that is bypass graft. So check which vessel it is where you are applying the graft and which particular vessel you are harvesting for the grafting material. That also you have to check and two separate codes has to be used. Few codes in this part you will see add-on codes. Whatever add-on codes you will see, these are for the harvesting of the vessel. So if you see the very first code 35500, it is for the harvesting of upper extremity vein. Remember, I told you there are exceptions with cabbage procedure. Upper extremity artery, upper extremity vein, and femoropopliteal vein. If you harvest, then harvesting of those vessels you code separately along with cabbage. But those codes were not listed there. But I made you highlight into the guidelines. Those codes are actually from here. Any harvesting of the vessel is being done. All the codes for harvesting of the vessels are listed in here, as well as the graft, where you apply the graft in between two vessels. If you're applying the graft, so where exactly you apply the graft, you check and you assign the codes. So these codes are direct based on the location again. Then you have got this other than vein. So all these arteries, veins, all types of grafts are listed in here. So no need to go. That is all bypass graft. Then there is a procedure called composite grafts. Composite grafts are nothing but, say, I don't have any healthy vessel in the body to be used as a grafting material. What I'll do? A prosthetic vessel I will use, like a catheter. A prosthetic vessel, a artificial vessel, they use it for grafting purpose. Then you call it as a composite graft. So all the composite graft codes are add-on codes. Next, you have adjuvant techniques. So there are a few codes for these adjuvant techniques. Again, these codes are based on the location. Hardly 2 codes are there. Then you have got arterial transposition. So transposition is whenever the artery should originate in one place, it is not originating in that same place. Then you call it as a transposition. So whatever transposition, which vessels are transposition, you have to check, and based on the location, you again assign the codes. So here, when you're coding into the last part of the chapter, arteries and veins, always you have to check which vessel you're treating. Based on the name of the vessel, you have to keep assigning the codes. Next procedure is excision, exploration, repair, or revision. If any vessel, I'm going to explore it, explore as in to find out what is wrong inside, or I'm going to remove the part of the vessel which is damaged or repair it. Then all the codes for all such procedures of excision, repair are listed. Again, the codes are dependent on the location, which part of the body I'm going to do the procedure on. Based on that, you have to assign the codes. Next procedure is vascular injection procedure. To understand this procedure, I want you to open Appendix L also. Keep your Appendix L open, and then we will check the guidelines in place. There. Oh. Vascular injection procedure. Under vascular injection, you will see 4 subsections are there. First of all, whenever I need to inject anything into the patient's body, be it medication, saline solution, I need to puncture a vessel. Either I just put it into a vein or put it into a artery. So 2 types of vessels are there, either artery or vein. So I am going to say deliver a medication into a vein. I call it as intravenous injection. If I am going to deliver it into an artery, it is called as intra-arterial injection. Injection is one-time procedure. I just simply push the needle into the vessel and I push the medication, done, I take it out. But sometimes your patient need the medication over a period of time. So what you have to do is you have to secure a catheter into the vessel. So you slide a needle first. Over the needle, there will be a small catheter. You slide that catheter and that catheter is placed into the vessel and one end of the catheter will be outside. So you can keep on giving the medication once you have secured the catheter in place. Through that catheter, you can keep on giving the medication to the patient over a period of time. When I'm going to secure the catheter, I just have to check in which vessel I'm going to put it. Sometimes you put it into the periphery of the body. So that is maybe the vessels of the arms and legs you choose and you push a catheter in there. So that is called as basically a catheter placement. For the catheter placement, you do have codes here and then you give on medications. This is one purpose where you push the medications. But sometimes I place a catheter to take out some blood from the body. Why I need to take out the blood? Either for investigations or for blood donation. So such procedures, when I take out the blood from the body, that is listed separately. When I secure a catheter for taking out the blood, either for investigative purpose or for donation purpose, the codes will be listed separately. That is called as venipuncture or arterial puncture you do to take out the blood. Next is another. So this all procedures when you do into the periphery of the body. But there are certain vessels which are located very close to your heart. So the vessels which are into the periphery, these are fragile. Fragile as in if you secure a catheter, you keep on giving the medication. If it's a very strong medication, the vessel will sustain for a day or 2 or 3 maximum. And then the vessel will get damaged, collapsed, and no more medication will go. So, for patients, usually when they undergo chemotherapy or a stronger medications needs to be delivered, or for a long-term medication delivery, you prefer the vessels which are strong enough, which will not damage easily. That is the vessels which are big vessels like your subclavian vein, jugular vein, and so on. So all these vessels you prefer. When you push a catheter into those vessels, it is called as a central venous access. For that, again, you will have separate codes. Okay. So whatever is listed here under vascular injection, these are the codes for securing a catheter into the periphery of the body. Apart from the vessels which are related to heart or in the center of the body, apart from that, from the periphery, you are reaching out, then you use these codes. The codes are classified into intravenous and intra-arterial. There will be 2 sections. This is when you use this catheters to deliver the medication. Now, when you are coding into this particular part, I am pushing a catheter. I just need to know which vessel it is. And when I know the vessel, I have to understand what is the order of the vessel. Based on the order of the vessel, the code will keep on changing. If I have pushed the catheter into first order vessel, second order vessel, third order vessel, I have to check that. And then based on that, I have to use the codes. Like if you go down, intravenous section is there, right? So intravenous section, if you see these codes, 36011, 36012. Can you see? They have mentioned selective catheter placement, venous system, first order branch. When I am going to push the catheter into first order vessel, I use this code. But if I am going to push the catheter into the second order vessel, the next code, 36012, that is the code I have to use. So based on the order of the vessel, my code will keep on changing. To define or to understand the order of the vessel, you have to use appendix L. So say my doctor is pushing here. You have this is for the vascular families, arterial vascular families we saw. Similar way, you will have venous vascular families starting on the page 996. So say I am going to place a catheter into right jugular vein. So right internal jugular vein, I am going to place a catheter into. I have to know what is the order of this vessel. For this particular right internal jugular, it belongs to second order vessel. So I have to choose a code. If the catheter is placed into this vessel, then I will choose a code for the second order. So here, when you choose, when the doctor is going to place a catheter into right internal jugular, I should choose the code 36012 for selective catheter placement into venous system, second order vessel. Okay. So always you have to go ahead, use your appendix L. Doctor will mention where he has placed the catheter, into jugular vein or into artery or into any other, whatever the vessel is, the name of the vessel will be given to you. You have to go ahead into appendix L, check what is the order of the vessel. Based on the order of the vessel, you have to assign the code. First of all, check whether it's an artery or vein. Go to that separate section, then check the order of the vessel and then assign the code. Now, when I am going to push the catheter sometimes what happens is, say, check this diagram. Okay. When I'm pushing a catheter, I'm just say starting like pushing the catheter from say this right internal carotid. I have started pushing the catheter. Then I push down it's into the right common carotid and then I took it into the brachiocephalic. So I'm going from the third order vessel to second order and then to the first order. That doesn't mean I will keep coding for each order. Whatever is the final location of the catheter, wherever the final end of the catheter is located. Is it into the first order vessel or second order or third order? You have to check that. And based on the final location of the catheter, you are going to assign one single code. Okay. Another thing is this catheter placement is classified as selective or non-selective. Selective meaning when I am going to place a catheter into the great vessels. Okay, directly into the great vessels, the end of the catheter is into the great vessels, then it is called as non-selective. Because further cannot select. Directly those vessels open up into the heart. I don't have any more selection. So any catheter which passes through this great vessels is called as a non-selective catheter placement. If the catheter is going to be placed into any other vessels apart from the great vessels, then you just call it as a selective catheter placement because you can further select whether I want to keep it into first order or second order or furthermore into the beyond third order, whatever it is, I can select. So that selection is possible and that's why it's called as selective. So non-selective meaning when you place the catheter into either superior or inferior vena cava, aorta, pulmonary artery, pulmonary vein, anywhere you place it, then you call it as a non-selective placement. But apart from these vessels, if I place a catheter anywhere else, then it is called as a selective catheter placement. So when you are coding into vascular injection procedure, you first have to go ahead and check whether it's an artery or vein. Then you are going to check where the end of the catheter is located. Only for the end of the catheter you are going to code. That is, you will code based on the order of the vessel. For that you will use appendix L, decide the order of the vessel and assign the code. And lastly, you have to check whether it was selective or non-selective. And one more thing you have to check if multiple catheters are placed. Say I'm going to place catheter into 2-3 vessels. Like say I'm pushing one catheter from this right internal carotid to this right common carotid, and another catheter I'm going to push from right vertebral into the right subclavian. So 2 catheters I have placed to deliver the medication. Maybe when I'm pushing 2 different catheters, I have to code them separately, but when I am coding for these catheters, one base code, primary code I'll use and one add-on code I have to use if they belong to same family. When I am going to place the catheter, I have to check which vessels they are going to put in. If both the vessels belong to same family, use one primary code and one add-on code. But if, like here, it is belonging to same family, right? Right internal carotid to right common carotid. And so the catheter is placed into right common carotid. Right common carotid originates from brachiocephalic. And when you see right subclavian, it also originates from brachiocephalic. So both this belong to same family. I will use one primary code and one add-on code for additional vessel. But if say one catheter is placed into this right common carotid and the other catheter is placed into this left subclavian. So when I check the families of this vessel, they belong to different family. If it's different family, 2 primary codes to be used. For each family, you will see a set of 4 codes. Like I'll show you. Okay. Here it was for intravenous. If you go to intra-arterial section, under intra-arterial section, check these codes. 36215, 216, 217 and 218. Check these 4 codes, 215, 216, 217 and 218. These 4 codes are for one family, that is brachiocephalic family. If you read the description of the code 36215, that says selective catheter placement, arterial system, each first order thoracic or brachiocephalic branch within a vascular family. So when I place a catheter into first order branch of any vessel which belongs to brachiocephalic family, I use the code 36215. If I place the catheter into second order branch of this brachiocephalic family, the code is 216. If I place the catheter into third order branch of brachiocephalic family, then 217 is the code. There is the add-on code. Add-on code 36218. It is for additional vessel. Either it belongs to second order, third order, or beyond third order from the family, brachiocephalic family. Then for additional vessel, a add-on code to be used. So everywhere for every family, you will see a set of 4 codes. This is for brachiocephalic family. Similar way for other families, it will be there. So from that family, you are placing a catheter into first order vessel, second order, or third order. Use a primary add-on code for additional vessel. But if the vessels belong to different families, use two different primary codes depending on the family of the vessel. So that is for vascular injection. First of all, check intravenous or intra-arterial. Go to the respective areas, check whether it is selective or non-selective. Check whether it is into first order, second order, or third order. If multiple catheters are placed, then check whether the catheter where it is placed belongs to same family or different families, and accordingly you assign the codes. Any doubts? Okay. Get me a code for placement of catheter into right internal carotid and right external carotid. Right internal carotid artery and right external carotid artery. In both these arteries, I am placing a catheter. Get me a code. Okay. First of all, check whether it is vein or artery. I said right internal carotid artery and right external carotid artery. So basically it's what? Artery. Go to the part that is intra-arterial. Now to choose the code, first go to appendix L. Check which family these vessels belong to. Which family they belong to? For that you use your appendix L. Which family these vessels belong to?
Second order.
Yeah, order is second order, but which family they belong to? How do you decide? We saw that in the last class, right? You will keep going down till your first order vessel. Whichever first order vessel they originate from, that is the name of their family.
Thoracic aorta.
That is not a first order vessel, right? Sorry? Yeah, common carotid. Is it a first order vessel? No. It is a second order, right? Common carotid.
Yes. Second order.
Second order it will be. Common carotid vessel.
Second order.
Okay, here. Common, right? Common carotid you said, right? Okay, but they I said right internal carotid and right external carotid. So they originate into right common carotid, which is a second order vessel. Then I go one more level down. Then I see they originate from the brachiocephalic. So brachiocephalic is the name of the family for these two vessels. Okay. So both the vessels belong to the family brachiocephalic. They belong to same family. Now I have to go and find the code range for brachiocephalic family. So the codes will be 215, 216, 217, 218. That is the code range for brachiocephalic family. When you go in there, check what is the code for the third order vessel, because I asked you to for the placement of catheter into right internal carotid and right external carotid, which both of them are third order vessels. So the code for the third order vessel is
Is it 36217?
so 36217 for one vessel. Now I am placing a catheter into two vessels. For the first vessel, I use 36217. For the additional vessel, which code should I use?
36218.
36218.
36218.
Okay, so two codes will be there, 36217 and 218. Two codes you have to use. Because I am placing a catheter for two vessels from the same family. Okay. Similar way for other families also, you will have code range. Different code range will be there. So always when you're coding for vascular injection procedures, go to Appendix L. First of all, find out it's a vein or artery. Then find out what is the family of that vessel. Then check whether it's first order, second order, third order vessel. Based on that, you assign your code. Okay. It will be little confusing, difficult, but this cardiovascular system is going to be like that. That was all for vascular injection procedure. After vascular injection procedure, if you go, I told you, this all codes are used when you place a catheter to deliver the medication. This is the code only for the placement of catheter. When I'm pushing the medication, separate codes will be there for pushing the medication, because usually nurses will give those, administer those medications, and doctors will secure the line. Now, securing the line, these are the codes. For delivery of the medications, we will see separate codes listed under medicine chapter, because it's not like a surgical procedure. Just pushing the medication, it's not a surgical procedure, so the codes are not in here. The codes are listed into medicine chapter, which we will see later on. That was when I secure a catheter to deliver the medication. When I'm securing a catheter to take out blood, you will see this section, venous section. Under venous section, all venipuncture codes are there when I am taking out blood for either investigation or for maybe to treat the certain conditions or for blood donation. When I do that, the codes will be listed here. Check what is the reason to take out the blood. Based on the reason, you will have codes. After venipuncture codes, if you go further down, you will see there are codes for central venous access procedure. Okay, I told you when you are going to place a catheter into the vessels which are major vessels in the body, then you use the codes listed in here under central venous access procedure. There are few guidelines here. I'll come back to these guidelines. After that, you go further, and on the page, what is it? On the page 304, you will see arterial section. So whenever I'm going to puncture an artery to take out the blood, sometimes for investigative procedure, it's not sufficient to take out the blood from the vein. Maybe I need to measure arterial blood gases, or I need a blood from the artery for investigations. Then I'm going to puncture an artery. So you have got the codes listed here under the arterial section. So 4 different sections so far we checked under vascular injection, that is intravenous, intraarterial, when you secure a catheter to deliver the medication. Then there was a venous and arterial section when you take out the blood by puncturing the vessels. And then I left that part, that is central venous access procedures. There you can come. Before going to the guidelines of that part, what we do is we will check a video where they have explained the types of central venous access procedure. Okay, here, page number 398. Sorry, 298. Central venous access procedure. I told you when I am going to place a catheter into the major vessels, which are centrally located in the body. So either I place the catheter, which is a major vessel, which is located in the center of the body. That is either jugular vein, subclavian vein, femoral vein or inferior vena cava. If I am that like placing the catheter in this, that is called as a centrally inserted central venous access. But sometimes I start threading the catheter from the periphery of the body and push it near to the heart. So when I do so, then it's called as a peripherally inserted central venous access. So when I start pushing the catheter from basilic, cephalic arteries or veins or into the saphenous vein, these are the entry sites, then I call it as a peripherally inserted. So you check whether the catheter is centrally inserted or peripherally inserted. Definitions are given here into the very first paragraph under central venous access procedure. Then I have to check whether the catheter is tunneled or non-tunneled. What is tunneled and non-tunneled, I'll explain in some time. That you will check the second point. And then lastly, you will check what they do with the catheter. They are inserting it, removing it, replacing it, repairing it, what they are doing with the catheter. And all the codes in this area will be age specific. You have to match the age of the patient while you are choosing the code, and then you can choose the code. So for central venous access procedures, first check what they do with the catheter. Insert, remove, replace, repair, or whatever. What they are doing, check. Then check whether it is centrally inserted, peripherally inserted, whether it is tunneled, non-tunneled. And then check what is the age of the patient. And then by matching that, you can assign the codes. Now I'm playing a video to make you understand what is tunneled and non-tunneled catheters are. And then we can go.
This animation shows how a tunneled central line is put into a vein close to the heart. Click the navigation arrows below the animation screen to play, pause, rewind or fast forward the animation. A central line is a narrow, flexible tube which can help give treatment without the need for repeated injections. It's used to give medicines, intravenous fluids, and take blood samples. A small cut is made in the skin near your collarbone. This is the entry site. The tip of the central line is threaded into a large vein and towards your heart. Part of the tube is tunneled under your skin to reach an exit site on the chest. Part of the tube will sit outside your body. You may have a local anaesthetic to block feeling in the entry and exit sites. Here we show the tip of a central line, part of the tube tunneled under the skin towards an exit site. The other part of the tube remains outside the body. The entry site may be closed with stitches and covered with a clear dressing. You will have a chest X-ray to make sure your central line is correctly positioned.
Okay. So if you see the central line, it has got two parts again. This part which you see outside, this is called as a pump, and the part which is inside the body, that is a catheter, cannula is there, which you thread inside the body. So whenever replacement is done, usually if the pump is not functional, I'll just remove that outside part and I'll replace with the new one. But if the catheter is damaged, then I am going to just only pump, I'll keep the same, but the catheter I'm going to replace. So partial replacement, that is called as, either you change one part, that is either a catheter or the pump you change, that is called as a partial replacement. Whenever they are asking the questions for partial replacement, they'll confuse you. They will say, we do a complete replacement of catheter. Complete replacement of catheter, that doesn't mean completely entire device is replaced. You're changing the catheter completely means you're doing a partial replacement. So by reading the word complete, don't get confused. Complete replacement of pump or complete replacement of catheter, when they use such words, it is partial replacement. Okay. Usually they do so to confuse you in the exam. So here, when you are going to go check the codes into your code book, So they have given these definitions, what is called as insertion, what is repair, what is partial replacement, complete replacement, and removal. First check what is the procedure they do. Everyone understood what is tunneled and non-tunneled, right? Tunneled meaning when they are going to just place the catheter. When you to thread the catheter into the patient's body, you take an incision, and through that incision you start threading the catheter and push it into the whatever vein you want push it into. You'll place it there. Once it is placed, if I keep the end of the catheter open, then I call it as non-tunneled. But usually you'll not do so, because there is a chance that the catheter, with slightest movement, it can get displaced. You are placing it already into a major vein, so bleeding can happen if the vein is damaged. So what you do is, to secure the catheter in place, you are going to push it below the skin, take it out from another end. When you do so, it's called as tunneled catheter. Usually to avoid infections and for the to avoid the displacement of the catheters, they will do the tunneling of the catheter. If it is done, it is tunnel catheter. If the end of the catheter is kept open from the entry side, you call it as non-tunneled catheter. Now here, when you are going to code, you are going to check multiple things. First, check what is the procedure done with the catheter. For every procedure, separate code range is given. If it's insertion, this is the code range. Then if it's insertion done, then further check whether it is peripherally inserted catheter or centrally inserted, whether it is tunnel or non-tunnel, and check what is the age of the patient, match these things, and then you can choose your code. These are all different codes for insertion. Then if you go down after this table, you will see there are codes on page number 302, 302 page number. You have codes for repair. Separate code range for repair is given. Then you have got codes for partial replacement separately given. Then you have got codes for complete replacement. Then there is a separate code range for removal and separate codes for other procedures. Everywhere you will go ahead, whatever the procedure, you'll go to that code range, you'll match centrally or peripherally inserted, tunnel, non-tunnel, and what is the age of the patient, you match and then you assign the codes. That was all about central venous access device. Any doubts?
No.
Under vascular injection, 5 different types of codes are there. One is intravenous, intra-arterial, then only venous and arterial sections for taking out the blood, and then central venous access procedure. These are all different codes listed under vascular injection, where you secure a catheter into some vessel. Next, you have got hemodialysis access or shunt. This is a surgical procedure. All of you understand what is hemodialysis? Dialysis, whenever your kidneys are not functional, what kidneys do? They are responsible for filtration of the blood. If kidneys are not functional, then you place the patient on a dialysis. For putting a patient on dialysis, you cannot just start the dialysis directly. It's a device which you need to connect to the patient's body. To connect it to the patient's body, first you need to create a dialysis circuit inside. Meaning, you are like we did for ECMO. You insert a cannula. Similar way, for this hemodialysis also, you insert a cannula called shunt. So, you insert either that cannula. So, from where the blood will come out, it will pass through the dialyzer. It will be filtered of all the impurities. Then the purified blood is put back into the patient's body. So that is why you use that cannula, or that is what is you call it as a shunt. Or sometimes you have to create the entire circuit. So from one vessel, the blood comes out. From another vessel, it's going to go back. So purified blood, when you are going to put back, it should directly be pumped to everywhere into the body. So you put back into a artery. When you take it out from the vein. So like that, it's going to happen. And that is what the dialysis circuit, when you are going to create, you create an abnormal connection sometimes between an artery and vein for that. That is arteriovenous fistula has to be created. It's not already present, you have to create it. So for that, surgical procedures are required. When you are doing that, the codes are listed in here. for hemodialysis access. To give the access to this dialysis device, you need to perform a procedure. Either you insert a cannula, shunt, or you create that arteriovenous fistula and create the entire dialysis circuit. That is what is the codes are here. But when you directly connect the device to patient, that is just the device you are going to connect, that dialyzer. For that, the codes are into medicine chapter, not here. Okay, so here all these codes similar to what ECMO codes we saw. You have to check what they do, insert it, remove it, replace it, repair it, create that fistula, create like connect a artery, vein, whatever it is. So all different codes will be there. The location of the vessels. So you can create it either on the hand, leg, neck region of the patient. So which vessels you use to create that circuit, you have to check based on the location. You have to assign the codes. So all these different codes are there. I'll not go into the details. It's same like your ECMO. So dialysis circuit codes are there after that. And then you have got the next procedure, that is portal decompression procedure. Portal decompression is whenever any vessel is getting compressed somehow because of the external pressure, some pressure from the tumor, some pressure from some other body part, there the vessel is getting compressed. You need to release the pressure on the vein. That is called as decompression. For all this decompression, you have got codes listed in here. This decompression, where you do that, which vessel you are treating by this procedure, you have to check, and based on that, you assign the codes. After that, you have got transcatheter procedures. Any procedures I do by using a catheter. So, this all codes are here. I can do many procedures, like earlier also we saw thrombectomy, embolectomy, and so on. All these procedures I can perform by using a catheter. I need not cut open the patient all the time. So if at all I'm going to perform any of these procedures by using the catheter, the codes are here. But when you do transcatheter procedures, you will use a radiologic guidance also. Like when I'm pushing the catheter, I need to know whether the catheter is going in a right direction or not. So I will usually use a radiologic guidance. Sometimes the radiologic guidance is included with the codes. You have to read the code description. If the radiologic guidance is included with the code, do not code that separately by using the codes from radiology chapter. But if at all that guidance is not included with the code description, then you will use one code for the procedure and another code for the radiologic guidance separately. But with this transcatheter procedure codes, radiologic guidance is included, and you should not code it separately. Where you are doing the procedure, on an artery or on a vein, thrombectomy, embolectomy, whatever it is. So you have got arterial mechanical thrombectomy and venous mechanical thrombectomy codes listed. Thrombectomy is removal of the thrombus by using a catheter. So from a vein or from a artery, you are removing it, check it, and match the description, use your code. After that, you have got endovascular repair again, endovascular revascularization, and now this is for the last part of the aorta. This is going to need another 1 hour for me to explain. So with this, I'm going to stop and then I'll continue in the next class. Just give me a minute. Hello? Hello? Vascularization I was talking about. This endovascular revascularization has lot of guidelines. Okay, it will take another 1 hour for me to explain, and I think it will be too much for you for today. So we will stop with this and we'll continue. This is the last part which I have to explain from cardiovascular system. With this, once I finish this, we are done with this chapter. Okay, so we'll do it in the next class. Till that time, whatever questions are there in your worksheet, whatever questions we have not solved today, those questions from the worksheet you can solve later on, okay, as your practice questions. So here we have not done this question number 4, 5, then okay, these are all questions you can solve. Okay, so this 5 questions you can do till your next class, and then we will complete this particular topic in the next class. Okay. Okay, so that is all for today. We'll continue next Sunday. Okay, so there is a long holiday coming towards the end of May. All of you want to have off, or are you comfortable taking up classes on that holiday? Because 2 Sundays we will miss if we take a holiday to attend classes. Yeah, so
Yes.
I'll just, it's okay for everyone to attend classes, right?
First, it will be Sunday, right? I don't understand.
Yes.
The May 22nd onwards, I think there is a holiday.
Because for me, sometimes I'm working. Last week I was working in the public holiday, right?
Yeah.
Yeah, I was working last week. Just
So check if everyone is comfortable attending the classes, then we'll have the class. Otherwise, we'll take it as a holiday. Okay. So like there is still time. You can check at your workplace what is the situation at your workplace, and then let me know. Okay.
so in that case, it would be like online, offline. It's
That I'll confirm the day before, because if they are keeping the institute closed, then we'll have an online class. But if it's open, then we can have it here. Okay, see you all.